Thank you very much for this kind invitation. It's an honor. So I've been challenged with the title, which is speaking about the long-term outcome of pediatric split graft recipient from childhood to adulthood, knowing that most of the literature and the evidence we have in the literature is concentrating on the split graft outcome less than 5 years. I mean, there are a few series where they go up to 10, but there is nearly no data in the literature for above that. One important point to remember when we are looking at very long-term outcome is that we have been improving in time. So when we are looking at 30 years of split activity, which is nearly the whole activity of split we have done, because we started more or less 30 years ago, we have the impact of the fact that we have been improving a lot from the late 80s when it started. It started in 88, the first split, and we have been improving. So when we look at the curve up to 30 years, we get the effect of the learning we had in the past, and it is very likely that the very long-term outcome we will have starting from today when we do a split tonight will be different, will be a little bit better. So saying that, I will spend only one slide on the short-term outcome. This is a slide you already have seen. Pediatric split liver graft is equal to whole liver. And you see this is a slide from ELTA, the European Liver Transplant Registry, where you see that in the last decade, we get as good outcome independently of the type of graft, which means in Europe, when we use a full size, a split, and even a living donor, in small children, we get equal outcome. I'm a little bit disappointed by the result of living on that slide, but I mean, these are facts. The long and very long-term outcome is a problem as we don't have data in the literature. So what I did is that I asked the European Liver Transplant Registry, and I want to thank especially Valérie Caillé and Vincent Karam who did that work. So we did an extra selection for this lecture, looking at the very long term, specifically about the split grafts that were implanted as first transplant in children, and this covered the last 30 years, 90 to 2020. You remember that there were only 5 or 10 split done before the year 1990. So it's about 4,013 split graft, and I will concentrate on graft survival. You will see a few slides about patient, but I will concentrate on the graft survival to have exactly an idea of what's going on. So this is the first slide, overall survival, 4,000 split, and you see that at 5 years we are at 75% graft survival, and we reach 20 years after the number of split is very low. You see 12 and 7 over the 20 years, but we reach 56% overall right and left split transplanted into children. That's not bad. These are the numbers, and you see that after the first year, where we drop suddenly to 80%, 81%, the slope is only just a little bit above 1% annual graft loss rate, which is incredible because in adult you go 4 times rapidly down. So it's interesting. This is a slide you already have seen today. This is a slide calculating the graft half-life in children in 16,000 children transplanted in Europe. And this was the calculation we did with 30 years overall half-life. Now, if we go and mix that with the slide you have seen about the split, you see that split graft as first organ transplanted to a child is nearly mimicking the overall. I mean, there are a lot of full-size liver and living donors in that slide. But you see that splits are doing nearly as good as, they are doing as good. And you see a little drop there, but you see we are coming around the 20 years, which means we are speaking about patients who have been transplanted before the 2000. So I can say that this was the learning curve, and you see there is not very much difference. 49% survival at 20 years for the split and 50% for everything else. Now, good thing is that right and left are doing more or less equal. And the slope is the same. You see that there is no major difference. But it is slightly significant, this slight difference. Now let's go to patient survival and say I will not give you a lot of patient survival, but I want just to honor the fact that patients are doing even better. We have a 73% survival of the patient for children who have been transplanted with a split as a first organ. That's incredible. And of course, if you calculate right, 73% means that 2/3 of the patients still have their first graft, but 1/3 have been retransplanted. It means 2/3 of the patients 25 years after, when they get a split graft, they still are living with their first organ. Are all candidates equal? We have seen before in the afternoon that the outcome of a graft is depending on the age of the child. And we found that as well. So if I look only at left split graft in order to have a good picture, only the left split graft, the graft survival is different and the slope is different according that they are transplanted before the age of 6, if they are 6 to 12, or if they are less than 12. And you see that these two curves are nearly close to each other. The big difference is that one. And this picture you have seen before, where obviously the children who are less than 6 and 6 to 12 behave the same way, much better than any other group, and they do better than the 12 to 18. The 12 to 18 are behaving like young adults. So we found that even when we look only at split graft. So there is something strange. And you see this is, again, the same picture. This box is there, this one is there, and the yellow one is the young adult. Very, very long term, what happened when they become adult? Because that was one of the questions. So I was in trouble because, not every patient is going to the adult age. In this series of 4,000 split graft, at the moment, at the time of the analysis, only 13% were still alive above the age of 18, and 0.9% died after 18. The large proportion, 60% of the patients are alive, but still too young to cross the 18th birthday. And a few of them are dead, of course. So what I did is that I tried to match this age. So the effect of the transition to adult age is different for the child, because the child who has been transplanted at the age of 1, he spent 17 years with his graft before crossing that age. And different age are different times. So what I did is that I asked to LTA to make a conditional survival at age 18, and we looked only at the patient who reached 18 and what happened after. So that's a very special way of looking at things, but I did not find anything else to have the effect of transition and what happened when they are surviving and arrive in adult age with a split liver graft. And this is a number. You can see that at 5 years after the crossing the age of 18, because this time 0 is age 18. 95% survive another 5 years, 89 another 10 years, and 76% of them are crossing the age of 33, which is quite good. But now you see that there are two different slopes. One is quite smooth, less than 1% per year of loss, and the other one is a little bit sharper. And if we go and we analyze again with transplant age, you see that patients were transplanted before the age of 6, and of course, because they already have been spending 30 years, there are not many, and you see that we stop around 10 years, but 96% of the patients who reach the age of 18 surviving are still surviving 10 years after. And the drop is different if you go for older age. If you look at the split graft, not anymore about the patient, you see that the trend is even further. It's confirming that the two groups, less than 6 and 6 to 12, are behaving the same way as they were doing in the general analysis of 16,000 patients in the LTA. And the patients who have been transplanted at age more than 12 behave exactly like that. So we find with only the split graft exactly what we found with the whole group of pediatric transplant in ELTA. Conclusion, The split transplantation as an organ is excellent for children transplanted before the age of 12. It's quite great for those who have been transplanted between 12 and 18 years of age. And there is a persisting satisfactory graft functioning in adulthood. So the transition effect is unclear. Possibly there is no effect. And what we see after transition is effect of age and not effect of graft or effect of long time with immunosuppression. Further analysis is, of course, necessary for that. Can we do even better? Remember that we have seen that, and this is a normal curve, a lot of the graft loss is within the first year. There is as much loss during the first year as you have after in 20 years. So we lose a lot of graft during the very early time, and it has been already said that it's probably depending of the technique, the graft preparation, the donor selection, and so on. So it's something that in the past we have been improving, and it's something that if we could improve, would gain not only the first year, but would push the line 10-15% up all the way through, which means pushing the half-life to 40, I would say even 50, who knows, the survival of this patient. We have done that in the past. You see, late 80s, late 90s, and the current decade, we've been pushing up. And in fact, the slope is exactly the same. They are all parallel. The only action we had, all the 30 years we've been working, is improving the first year of activity and the first year of outcome. So the best outcome we can achieve during the first year, the better the patient will go. We know it. It's normal. Now, can we do that? Yes, we can. This is a series of my teams in the last 15 years. A total of, I took only the liver division, which are the living donor, the right and the left split. Nearly 200 split graft and living donors. A majority of living, 57, which means there are 43% of split graft in that series. There was, in fact, graft lost by death of the patient, one case of multi-drug resistant sepsis, and 4 recurrence, one hepatoblastoma, one hepatocarcinoma, and 2 patients with severe immunodeficiencies. But because we have a protocol of selection of the donor, choosing and adapting the technique for splitting at the time of the procurement, and a very strict protocol of limiting the risk of thrombose and managing all the problems with aggressivity, this gave us overall 15 years of 97%. And you can see that the split graft, the left split graft, either the transparenchymal or the transmolecular, are the same survival, the same outcome compared to living donors. So this is probably what we can achieve if we control much better selection of the donor, preparation of the graft, and a protocol of avoiding any technical complication. That's probably the future. We need still to reduce the 10% graft loss we have during the first year to 1, 2, 3%. I think it's feasible. It will require a lot of attention and effort, but it is something that can be achieved in the future, I'm sure. Thank you very much.